Okay, so we are ready to start. So thank you all for joining us in WHO and also in IBP for joining us on this webinar on task sharing. This is obviously an important and global issue, and we have participants from 55 countries from all regions of WHO. We have participants from the African region, from the Eastern Mediterranean region, from Southeast Asia, Western Pacific, and also from the Americas. So thank you very much for taking a time to join us today. And also at the beginning, I would like to give a special thanks to Osa Cousin and Stephen Nash Findley, and who are here with us in WHO, and to Ados May, who works with the Implementing Best Practices Initiative, for the good work they have done to make this webinar possible. So my name is James Kiarie. I'm the coordinator of the Human Reproduction team here in WHO, and I'll be chairing this session. Please note that if you have questions, type the questions in the question box on the right-hand side of your screen, and we will forward them to the presenters, who will be able to respond to them at the end of the presentation. So can we have next slide? So I know a lot of you do not need convincing that family planning is what is the best buy for health, and that without family planning, the targets and the goals that we have set up in the global strategy for women, children, and adolescent health, and also in the Sustainable Development Goals and in FP 2020 will not be possible. And we know that there have been many case studies of what has worked in terms of task sharing, because we know that health workforce shortages really limit access to effective contraception methods. So we have this challenge of a very effective intervention, but that is actually facing a lot of challenges because of limitations in the health workforce. In fact, in a recent discussion we had, as you know, WHO recently issued new guidance on the use of hormonal contraceptive injectables, progestogen-only injectables, and HIV that emphasize the importance of counseling. One of the challenges really of implementing this guidance is the lack of adequate personnel and adequate health workers to provide this counseling. We know that there have been many case studies of what has worked and what has not worked. We now have more knowledge on what hurdles exist in this process and what opportunities there are. And we know that it is important for us to have programs on task sharing. This webinar will present us a chance really to discuss what do we need to do to move to the next level for task sharing. And again, just a reminder that if you have any questions, you can type them in the question box in the control panel on the right-hand side of your screen. So welcome to the webinar, and today we have 4 excellent speakers, and we have Mario Festin from the World Health Organization, who will talk about WHO task sharing guidelines. We have Jill Peterson from FHI 360, who will talk about monitoring and evaluation indicators for task sharing, with a specific focus on injectable contraception as an example of the monitoring and evaluation of task sharing. We have Ashley Jackson from Population Services International, who will talk about expanded access, empowered clans, the programmatic experiences with task sharing on long-acting reversible contraceptives. And finally, we'll have Rehanna Ahmed, who is also with Population Services International, who will give a country experience. So we hope that you will enjoy this webinar and look forward to getting questions from the participants and engaging with you. We have tried to balance so that we have the normative perspective the programmatic perspective, the monitoring and evaluation perspective, and also the country experience of actual implementation on the ground. So I'll now hand over to Mario to do the first presentation.
Thank you, James. And my topic is basically to talk about the global guidance on task sharing that has been developed by WHO. Next slide, please. So, basic question, what is task sharing? Next slide. As what James has mentioned, there has been this big problem about expanding expanding coverage of modern contraception. And many of you know about the FP 2020 goals, about the need to add 120 million new users. There are many factors, as mentioned, to ensure meeting this goal, including making sure that commodities are there, quality of care services, plus respecting gender and the rights perspective. The most important thing for this afternoon is to look at the adequately trained health providers, but they're not enough, and it is envisioned that task sharing will create a more rational distribution of tasks and responsibilities across cadres. Next slide, please. Next. So we're talking about cadres. This just refers to levels or categories of providers. There are many different definitions and terms being used, and they are in the guidelines. One common question is the difference between task sharing and task shifting. Very basic difference is that in task sharing, usual providers retain doing the task, but involve or expanding the roles to other levels or cadres of providers. Whereas task shifting may be delegating the task to other cadres so that it is intended that the higher level cadres or whatever would have more specific or more complicated tasks to deal with. But this is highly contextual, depends on the laws and policies, but there might have to be specific statements related to detection and referral of management of problems and complications, whether you're doing task sharing or task shifting. Next, please. These are the different guidelines produced by WHO. The two guidelines which are in orange color are the ones which have looked at the specific recommendations for contraception. The gray-blue colored one is actually a task shifting guideline prepared for HIV and AIDS, but it has some programmatic recommendations that can be looked at because we're looking at the programs for health providers and health workers. The one on the lower left is a task sharing policy brief to give a summary of the existing guideline, and the other one on the right, lower right, is dealing more with linkages for delivery for all of the services based on the H4 Plus program, but focusing on community health workers. Next, please. Next slide. This table comes from the Safe Abortion Task Sharing Guideline, which describes the different health worker categories, which we will not go into detail, but it just gives us what are the different levels or categories of providers, an illustrative description of who they are, and in a third column, it gives some description of what are the other terminologies or terms that were discovered or that were gathered during the systematic reviews for the guidelines. So for lay health workers, that is the term that we use, but this is what you people usually refer to as the community health worker or the village health worker. Next, please. There are problems with these cadre categories. As I mentioned, there are problems with definitions, terminologies. But when we look at guidelines, we have to look at how they are reported in the literature and to see whether they are defined so that we know who they are referring to. A lay health worker may be different from one country to the other. It is preferred that we have the training, the description of the training background and what are the existing competencies, but these are not always available nor stated clearly. So there are some issues regarding adaptability of guidelines. They're not always feasible because of legal, policy, or training issues. And one thing that is described in the programmatic guidelines was that remuneration and identifying the scope of work has to be identified when we make programs for task sharing. Next, please. This is an example of a mapping of what has been done for community health workers providing injectables in Africa. It gives us a description of the duration of training and whether they receive remuneration or salaries from the ministry or from somebody somewhere else. But even if they are volunteers, they receive incentives or other means of compensation. Next, please. Basically, the guidelines have 4 categories. One is that the practice for the cadre is recommended, and it shows with the green, bold green check mark. It is recommended in specific circumstances, which means there might be certain situations in which have to be imposed when a recommendation is going to be implemented. The yellow or golden check mark, which is only for those statements that are recommended in the context of rigorous research, and the red X mark describes that the recommendation is not to be implemented. Next. Next slide. This is the summary of recommendations from the Optimized Maternal Health Guideline. As you could see, there was a attempt to summarize the document in a easy to look at format, whereas at the top we have the different categories or cadres, and on the left side we have the different practices which are summarized with the different check marks, the green, the green against white, and the X mark. Next slide, please. This is from the Safe Abortion Task Sharing Guideline, which actually updates the Optimized Maternal Health Guideline, and it has more categories and has more specific recommendations for certain contraceptive methods. Next slide. As I mentioned, there is another document, which is the WHO, UNAIDS, and PEPFAR Task Shifting Guideline, which has 22 recommendations for services and programs. And it was in this document, first document, that task shifting as a public health initiative was described. So all the enabling regulatory environments for implementation, quality and sustainability, and organization are described in this document. Next slide. Next slide, please. Because of this task shifting in contraception, WHO RHR has come out with policy briefs and summaries related to how do we implement these guidelines across methods, across situations, across countries. These are on our website and are being updated to reflect the newer recommendations based on the updated guidelines. Next, please. So this is the research map on task sharing. There is a lot of guideline being, there are lots of research being done on different methods, and this is a mapping of where the existing research on injectables are being done, and they're shown by the different, by the colored countries. Next slide, please. So there are certain general considerations for the implementation of task sharing. These are shaped by specific cultural and political factors. The health national dialogue is important in order to look at utilization of interventions, willingness, and whether there's an expressed mechanism to be supported by interrelated health system components. The recommendations should be considered as packages, so you look at the entire program rather than individual activities. Next, please. So why task sharing and why now? We want to offer contraception to a wide range of providers. We want to look at the evidence and the experience that the different reports have shown, and we want to show that access to contraception is part of a comprehensive sexual reproductive health and rights package for men and women. And we have to look at how we can improve policies to allow effective use and skills and competencies of the workforce to make efficient use of the different levels of the providers. Next, please. So this is, to close my presentation, this is an endorsement from the Director General of the World Health Organization that task shifting actually represents a return to the core principles of health services that are accessible, equitable, and of good quality. This is a framework in which we now know about access to health services can be extended to people that is effective and sustainable. And she endorsed task shifting as the vanguard to bring back and to strengthen the programs related to primary health care. So this closes my presentation, and now I turn over to Jill for the next.
Great, thank you, Mario, and thanks to the organizers for allowing me to present today. I am going to be talking about monitoring and evaluation indicators for task sharing of injectable contraception. And then just to go straight away into the next slide, this picks up a bit where Mario was talking about as well. Sorry, you can go to the next. Yep, there you go. So as Mario mentioned, WHO recommendations for optimizing health worker roles were put out in the document shown here in 2012. And I've circled here in purple where you can see for injectable contraception by lay health workers, it gave it one of those green checks with the white background, and in the text it talks about that it should be done with targeted monitoring and evaluation. But the text didn't expand to say what does targeted monitoring and evaluation mean in this situation. So FHI 360 thought that guidance for M&E of lay health worker provision of injectables might be useful to other countries looking to implement community-based provision of injectables. And so we are working on a project now where we're attempting to help WHO to define targeted M&E for community-based access to injectables. We started this process by convening a technical consultation to come up with some key indicators. If you want to go to the next slide. But of course, you can't start just by writing indicators, as anyone in M&E will tell you. It's not that easy. So we needed to start first with outcomes and then think of activities before we could get to indicators. So we did this together through a facilitated process that included both small and large group discussions. And on the next slide, I can show you the outcomes that we started off with. And these are not perfect, not to say there's not wordsmithing to be done here and that each country project wouldn't want to improve these on their own or make them more specific. But when we're thinking, you know, globally or internationally, what might be applicable in various countries as far as outcomes for community health worker provision of injectables, we thought of three categories: training and supervision, service delivery, and safety and logistics. And so an outcome for training and supervision we came up with is that community health workers should have the capacity to provide high-quality injectable contraception services. Under service delivery and safety, we said all women, regardless of geographic or financial barriers, have access to family planning, counseling, and safe same-day method initiation, including injectables, in their communities. And then for logistics, we said that community health worker service provision should be reliable and consistent. And so those were the overarching outcomes that led our discussion. If you go to the next slide then, please. From that, we talked about activities, as I mentioned, and in the interest of time, I'm not going to go through the activities, but you can imagine what those would look like. And based on those activities, then, we came up with this short list of 4 essential indicators. We jokingly called them the Toyota indicators. They're the basic indicators that are going to get you where you need to go. So the first one is the number of community health workers certified to provide injectable contraception. The next is the number of community health workers who received at least 1 supportive supervision visit for providing injectable contraception within some time frame. We said 1 month, but again, that would be programmatically specific. Within 1 month after successful completion of a practicum. The number of active community health workers reporting an adequate supply of commodities, of course, making sure that once you've created the demand, the supply needs to be there. And then lastly, the number of injections provided. So again, these are the bare minimum indicators that we put forth that should be measured to ensure there's a robust, safe, and reliable service of injectable contraception through community health workers. And then next slide, please. Beyond that, then, we have some expanded indicators, and we came up with lots of other things. Of course, if without the constraints of a real project or budget, we can make quite a long list. But we tried to rein it in a bit and come up with, if someone did have the budget and the capacity to measure some other things, what is the Lexus or the more luxurious list of indicators that they might want to look at. And what we started with here, you can see at the top, we were thinking of it a bit in a cascade so that these numbers can be put into context. So you would start with the number of community health workers in the cadre, in the suggested cadre, and amongst those, the number who are trained in providing injectables, and amongst the ones who are trained, the number who are certified, which would mean that they've passed the written portion of the training as well as a practicum. And amongst those who are certified, the number of those who express confidence in their skills. And then amongst those who express confidence, the number who are active, so who've provided an injection in the last month. So we want to make sure that people who are being trained are actually using this skill on a regular basis. And then some of the other expanded indicators we looked at would be the number and percent of village or catchment areas with a certified provider to make sure you have good coverage throughout the country. And then the number of reportable incidents, including accidental needle sticks or infections or abscess at the site of the injection. So this is to get more in detail at some of the safety issues. And we called these reportable incidents because there's something beyond the regular expected side effects or some of the other things that that may need a referral back to a health facility but might not rise to the level of being something that we would call reportable. So the reportable is a bit more unusual or not part of what you would normally expect to see. So those are our indicators. If we move on to the next slide, then I can tell you what we're currently doing now is we're doing a landscape analysis in several countries. And through the landscape analysis, we want to look at countries who have been implementing community-based access to injectable contraception. There are several countries who've been doing it for a while now, or some, at least for the last couple of years. And from those countries, we want to know are they using these indicators that we've put forth or something similar? And how is that going for them? Are they wishing they had more data? Are they using it for decision making, for example? Also, are there any problems with the program? So since the time they've implemented it, what problems have they seen and how were those problems detected and how could we help other countries to do something similar to detect any problems along the way? Is the program successful? And what best practices are going on in that particular country that might be useful for other countries looking to implement this. So right now we're looking at Malawi, Senegal. We're hoping also to get to Zambia, Uganda, and possibly Burkina Faso. So those are the other countries where we want to conduct the landscape analysis and see what's happening there. And then the next slide. So at the end of this, what we will come out with are several end products. One is a summary of the current status of the practice in the landscape countries. And then based on what we learn there and our own expertise, we'll put together guidance for countries looking to implement community-based access to injectables. And then finally, we'd want to include some best practices, some sample tools, and some job aids. So that is the end of my presentation. Thank you.
Hi, this is Ashley Jackson. Thank you, Jill. That was great. And thanks to the organizers for this opportunity to speak. I'll be talking about programmatic considerations and experiences with the task sharing of long-acting reversible contraceptive methods. And I'll be speaking specifically about efforts to expand family planning options in Guatemala by enabling auxiliary nurses to offer all of the methods of contraception that they can safely provide. This work was funded by USAID Field Support through the SIFPO project. Next. In Guatemala, access to LARC methods of contraception is limited by both a lack of providers in general and a lack of providers with the necessary knowledge, skills, training, and supervision. As shown in this table, Guatemala has the lowest health worker density in Central America. Most healthcare providers there, particularly in rural areas, are auxiliary nurses who have an elementary school education or higher and roughly 1 year of training. As a result, we determined that it was critical that auxiliary nurses be trained to offer as wide a range of methods as they can safely provide. Next. Compared with the national average in Guatemala, the CPR is much lower among indigenous women who tend to live in the rural western highlands. And use of LARC methods, implants and IUDs, is particularly low. These methods are highly effective, safe, reversible, and well suited to the needs of many clients, which is why we focused on them. Next. The WHO guidelines that Mario spoke about recommend implant insertion by auxiliary nurses within the context of targeted monitoring and evaluation, and IUD insertion within the context of rigorous research. Next. But in Guatemala, national guidelines for family planning prohibited auxiliary nurses from inserting LARCs, even though in practice they frequently did provide the service without authorization. PSI's network member, Paz Mo, presented the WHO recommendations to the Ministry of Health and received permission to test whether auxiliary nurses in Guatemala's rural public health centers could safely and effectively offer implants and IUDs. We trained and certified 400 providers to insert LARCs within the context of informed choice and a wide range of methods. Short-acting methods and permanent methods were also available on site, and clients could freely choose whatever method they wanted or no method at all. Most of the providers we trained were auxiliary nurses. Others were nurses and doctors. And we did not train them to do removals. However, removals remained available through the doctors and nurses at the same facilities. So clients did not have to go elsewhere to access removals. Next. Quality assurance was provided by both Paz Mo and the Ministry of Health together through joint supervision visits, post-training follow-up visits, verifying the quality of counseling and volunteerism, infection prevention, privacy and confidentiality, skills and techniques to insert IUDs and implants. And whenever they identified gaps or weaknesses, they provided immediate feedback using job aids like videos and anatomical models. All of the providers trained did demonstrate proficiency. Next. As the availability of voluntary LARC services grew during this intervention, so did the percentage of clients choosing them. From 2012 to 2014, across all task-sharing intervention facilities, more than 6,000 women opted for IUDs, and more than 8,000 women chose hormonal implants within the context of informed choice. So short-acting and permanent methods continued to be offered and used at the same sites. In addition to these results, we saw higher client satisfaction and higher job satisfaction among auxiliary nurses. And as a result of this pilot study, Guatemala's Ministry of Health agreed that the 2017 update to the National Family Planning Guidelines may include voluntary LARC provision by auxiliary nurses at the national level. This step will ensure that task sharing and public health centers outlast the project. Next. This program provided an example of how implants and IUD insertions can be successfully task shared with auxiliary nurses with adequate supervision and follow-up. Auxiliary nurses are a valuable resource to improve the access to a wider range of methods in underserved areas. I also want to mention some broader considerations for LARC task sharing programs. When planning a program like this, it's important to ask, is there sufficient demand for the methods to justify task sharing of those methods? We sought to select facilities that had a high volume of clients, and many clients who had been seeking LARCs but found that the wait times were too long and chose short-acting methods instead because the doctors and nurses were unavailable to offer LARCs when they came. It's also important to ask if the cadre taking on a new task is a cadre that clients trust. And it's very relevant to select cadres who provide related tasks like deliveries. Oftentimes midwives provide deliveries but aren't yet authorized to offer IUDs and implants. And will the supervision and other functions be adjusted or task shared, if you will, to oversee this work? It's also important to ask if the cadre that you're task sharing with is motivated to take on this task. In this case, the auxiliary nurses found it highly motivating to be able to offer a task that was that required a higher level of skill. But that's not the case in every setting, and more interventions may need to be done to motivate them and help them understand the importance of these methods. And at the level of health systems, task sharing policies are sometimes in place but not yet operationalized. Those are missed opportunities that program implementers can seek to address. And in particular, within facilities, LARCs are often not task shared with mid-level cadres like auxiliary nurses. Furthermore, at the community level, the provision of implants can be done through community health extension workers in the context of rigorous research. And so that's an important opportunity to expand access to at least one LARC outside the health system. However, as you see in this last bullet, it's very important to consider LARC removals and who will be providing them, since that is really essential anytime you are providing LARC insertions. That's all. Thank you.
Hello, this is Rehanna. Hello, everyone. In the introduction, James stated that health workforce shortages limited access to effective contraceptive methods. Let me take it a step further. First slide, please. According to the Global Health Workforce Alliance, there are about 57 countries in acute crisis with workforce shortages. So my presentation is for advocacy, and I'm using Pakistan as the example to urge task sharing in view of these workforce shortages. Now, Pakistan continues to face considerable health challenges, and currently it lags behind in its international targets and promises. Next slide, please. The Lady Health Workers Program was initiated in 1994, and it aligns itself effectively by establishing a grassroots level system for provision of primary care. There are currently about 110,000 lady health workers serving mostly the rural poor, and that forms the largest community health worker program in the world. The Lady Health Worker Program has had formal evaluations of its performance, and it falls under the purview of the Ministry of Health. Next, please. Next slide, please. This is the picture of a lady health worker knocking on a door for a home visit. Next, please. Recruitment is, due to the cultural context, it is only of women. And these are women who are recommended by the community. And then there's a criteria for both age and education. The selected candidates then undergo a 15 months training, and there are monthly updates and annual refresher training as well. Next, please. The lady health worker role covers 4 basic areas. One is of basic health services and family planning, referring clients to nearby clinics, increasing uptake of public health initiatives, organizing health committees for men and women to mobilize the community and get them involved in these various initiatives. Next, please. The program implementation itself is very well designed. The lady health worker works from home, and their premise is called a health house. Each lady health worker is responsible for 1,000 persons, and that's approximately 150 to 200 households. Their work plan includes 5 to 7 visits a day, and they have several tasks, 20 in fact, maternal, child health, and family planning that they need to perform. There is a supervisor assigned to every 23 LHWs, which is 1:23, and in addition, the provincial and district coordinators monitor and evaluate the work of the lady health workers. Each lady health worker is attached to a health unit or facility nearby, from where they get their supplies and a small allowance. The salary is $343 USD annually, but the cost of the lady health worker overall is $745. But if you divide it by the number of persons allotted to her, then it really is very cost effective at 75 cents per person per year. Next, please. When you look at the SWOT analysis, we find that the strengths are there. It's a very well-designed system. It's under the Ministry of Health, and it's part of a whole program. And there is opportunity through task sharing to widen coverage of other services. There are, of course, threats, as always will be in such politically started programs, and those are when the politicians change, as well as financial. However, since it began in 1994, we have persevered, and the Lady Health Worker Program remains in place. Next, please. If we look at the results, and I have 2 slides as examples. First, when we compare over time key health indicators, the program began in 1994, and then there was a demographic and health survey of 2007, and there is the Lady Health Workers MIS system. As you will notice that the lady health worker served areas are performing well above the national performance. And the CPR alone is higher in areas where these ladies are serving, and children are far better immunized. In the infant mortality and maternal mortality rates are lower than the national figures in their served areas. Next, please. When you compare lady health workers' performance over time, there is substantial positive impact. Use of modern contraception, 11% more likely in LHW served household as compared to control areas. And there is positive impact on antenatal care, on immunization, as well as their clinical knowledge, which has been sustained and improved over time. Above all, they are serving the poorer rural households, and thus these lady health workers reach their targeted population. Next, please. Now, Pakistan is among the 57 crisis countries for health workers, and it lacks the means to increase skilled care very rapidly. So this is a short and medium-term solution, because a well-functioning lady health worker program already exists. These health workers are allowed to provide follow-up injections. However, the policy has not been yet amended to follow the WHO recommendation, which have been presented by Mario and again by Jill, and this is now long overdue. So this particular presentation is also a call to action for that policy amendment at a national level. And finally, there are other countries in crisis who could learn from the community mobilization program, which has been designed by the government for the National Lady Health Worker Program. I also want to share one point more with you, and that is that there is a plan to have a randomized control trial on safety and effectiveness. It is due to begin in the summer of this year. Jill did not mention Asia. She mentioned all the countries in Africa, but Pakistan Lady Health Worker Program, there will be a comparison between the lady health worker and the lady health visitor who's more clinically trained to see whether safety and effectiveness are in any way compromised by using the lady health worker to screen and initiate the community-based injectable programs. Thank you.
Thank you very much, Rihanna, for that very nice and succinct presentation. And thank you also to all our presenters, first for keeping to time so that we actually have adequate time for responding to the questions and for discussion. Actually, the questions have come very fast, and I can see more are still coming. So I'll do the first round, and the first set of questions is to Mario. And I'll just read out all the questions, Mario. So if you have a pen and paper, you can just note this down and respond. So the first question is WHO is prioritizing task sharing, or both task sharing and task shifting is prioritized. If both require policy recommendations, then why are they separated? This is confusing. Question number 2. I have a terminology question. When would we use family planning, and when should we use contraception? Third question, how would task sharing increase people's access to contraception? Through improving health providers' knowledge and capacity, or in which way? And the last and fourth question to Mario, task sharing has been under consideration for some time. What are some key challenges in getting policy or regulation endorsement? So Mario, if you can quickly respond to those questions, then we can move on to the questions directed to Jill, Ashley, and to Rehanna.
Thank you, James. I would like to thank the audience for the questions. Regarding the difference and the separation between task sharing and task shifting, it's mainly because of the way you design the program, whether it is task sharing or task shifting. Generally, the overall program would be on task sharing because the higher level providers do not always give up the tasks. And that is the trend now and more being used now, because we continue to involve the higher level providers in providing contraception, but just expanding some of the tasks to the lower level providers. We do not entirely shift them. But however, in some areas wherein there is an opportunity to shift some of the activities so that the higher level providers can handle more complicated or more advanced cases of the service delivery, that can be done. As I mentioned, this is highly contextualized. what is the difference between family planning and contraception? Contraception is the concept in which the pregnancy, the pregnancies, unplanned and unwanted pregnancies are prevented by the use of various methods and or either hormonal, fertility awareness based or permanent methods. Whereas family planning is a spectrum of activities that would lead to either preventing a pregnancy or actually ensuring a pregnancy. So that is the complete spectrum. For women who desire pregnancy, when it involves also planning a pregnancy and when is the time to do that. So family planning is the broader concept, but contraception is the more specific activity related to providing prevention of unplanned pregnancy. Now, how would we implement task sharing? As I mentioned, task sharing is one of the activities related, it's a whole program. It's not only implementing or training program, groups of people to provide services, but should also involve ensuring a referral system, ensuring that the providers get proper supervision, ensuring that resources such as commodities are available. If they have to be paid a salary or an incentive, that should be in place, because this is a health systems aspect, and in order to ensure that it will be sustained and acceptable to the population, it has to be many other aspects should be considered. But important to that is that the health providers should really be trained and updated in terms of knowledge, because knowledge is dynamic and there are lots of updates. So if a task sharing program is in place, at certain points in time, the providers, whatever cadre they are, should be updated on the latest technologies and the latest methods if that is allowed to them. What are the task sharing challenges? I already mentioned them in some of the discussions in response to the other questions, but it is really political will. If you want to do this, you can do it. Of course, policies are sometimes restrictive in countries because they want to ensure safety and quality. Some of the restrictions are also related to some of the other providers who are not very comfortable in sharing or shifting some of the activities. But I think one way of dealing with that is to involve them early in the discussions and in the planning, because part of task sharing and task shifting programs really involve supervision by the higher level providers and referral systems that involve them. So those are my quick responses. Thank you.
Thank you very much, Mario, for those responses. I have 3 questions for Jill. And the first question, do you recommend any indicators which can be used to ensure the quality of services? And the second question, what consideration needs to be taken to ensure that indicators measuring level of activity by community health workers do not translate to quotas of injectables? And the third question, when did the project start and when will it finish in Malawi and Senegal? Over to you, Jill.
Okay, great. Yes. Thank you for those questions. So the first question, recommended indicators around the quality of services. So we struggled with this a bit as we were working our way through this as a group, and then internally with FHI since then. I think we had to come up with how do you define quality, and quality to us was beyond just the safety issues. Quality was looking at is the program properly rolled out, and a big part of that is are the community health workers getting the supportive supervision? So we consider that to be a quality indicator. That is programmatically one of the biggest differences you can see to making sure that the services that are provided are high quality services. We also felt that even though you could look at the stockouts and supply of commodities to be, you could categorize that as a stockout or commodity issue, it really also is a quality issue. You don't want to have a program that creates a whole bunch of demand and 1 month is there and the next month is not. It needs to be reliable. So that again is a indicator of quality of services. We did talk about, again, as I mentioned during the presentation, the reportable incidents and making sure that what was being provided was being done safely. The programs we've talked to thus far, we've been asking a lot if anyone is directly tracking things like accidental needle sticks or infections or abscess, and what we're hearing anecdotally is that it's just not happening. And in fact, if it were to happen, people would want it to be dealt with in a more programmatic way than just through standard M&E. So the programs we've been talking to have been supporting the idea that rather than having that be an M&E indicator, number of accidental needle sticks, for example, that if something like that happened, it gets reported from the community health worker to their supervisor or directly to the health facility to which they report, and that it can be dealt with immediately and effectively that way rather than just recorded on a monthly tally sheet. So certainly both could be done, but the reason that we're hearing that people aren't doing that, for example, is just it's not happening often enough to make it really, really worth it. So all around the indicators we looked at, we're trying to really ensure the quality of services from different angles. Let's see, the next question was, how do you make sure that indicators that track the level of activity don't translate to quotas? Yeah, that's a concern, definitely. I guess the difference with a quota is if you're requiring a health worker to give a certain number per month, or if there's some sort of penalty to her if she doesn't provide a certain number of injectables. And rather than doing that, we're looking at it just to make sure that, again, that it's a double check to make sure, is the supply there, is the interest there, are you doing enough demand creation that you have a steady, that number, once your program is up and running, that number would probably be pretty steady. It might aspire to have some moderate level of increase there, but you wouldn't want to see super big increases. So your radar wouldn't necessarily be buzzing if that weren't increasing exponentially every month, for example. You would want to see it to be moderately increasing and or holding steady, depending on what other activities you had going on in that regard. And again, if you're consolidating the data and looking at it across several health workers, for example, if there are 10 community health workers that report into one supervisor or report into one facility, for example, if you look at it, if you consolidate those numbers and look at it across all of those providers and you're not individualizing it to one, that's another way to look at it. Of course, if there were a problem with one, an individual supervisor could look at that and could explore what it is, but if there's a problem with a particular health worker, but that would be more programmatically dealt with and less of an M&E quota type situation. So it would just be for that supervisor to say, hey, I noticed you didn't have many injections last month. Did you run out of supply, or were you feeling ill yourself, or what was going on last month? Certainly no penalty to the health worker for not having smooth performance every single month. So Malawi and Senegal, we've been working on those the past, I guess about probably the past 2 months or a little bit more, and we hope to wrap up those case studies soon so that we can jump in and start looking at some of the other countries. So the entire project should be done by the end of the year, but we need to get all of our case studies done first so that we can then write up the guidance based on what we're learning. And yes, Rihanna was right when she said that I didn't mention the Pakistan portion of the project. That's actually not one of our case study countries, but it's one of my colleagues, Dawn Chinqui at FHI, is doing an RCT in that area. So that's, we're doing more case study on our side, and then she's doing a more rigorous look at the data itself in Pakistan.
Thank you very much, Jill.
Sure.
I have another set of questions for Ashley. And the first question Are you doing any train of the trainer type situations to spread the number of staff to insert LARCs? And the second question, the option of removal as a minor surgical procedure by qualified staff available is a very smart intervention. Removal through the small hole as big as the one through which implants are inserted can be an added skill for auxiliary health workers. I guess the question is whether that skill can be also, the community health workers can be given that skill. And in the third question, in Zimbabwe, the fact that removal of LARC wasn't provided was a deterrent for women, as they knew they would have to pay a lot for later removal. What was your experience, or was it free and easily available? Over to you, Ashley.
Thank you. So first, trainings of trainers were not actually done in this project, but in many of the other projects that we do, yes, we use a training of trainers model to cascade the skills more quickly and sustainably across a geographic area. That's a great question. And removal, yes, it absolutely can be a skill that can be task shared. So the the WHO recommendations for LARC insertions are the same as the WHO recommendations for LARC removals when it comes to task sharing. But in this particular project, they decided to leave the removal service as something that only the doctors and nurses provided, so that they could focus first on making sure that the auxiliary nurses were prepared to do the insertions. And that was also an opportunity afforded by the fact that we were doing task sharing within facilities. So we knew that the doctors and nurses would still be on site and still be available for removals, which in response to that last question, were free and easily accessible. So they were accessible at the same point of service where insertions were being provided, and they were free through the public sector. So removals were still available, but my very final recommendation was around the need to also explore the task sharing of removals. And this may look different for IUDs and implants because IUD removals tend to be easier to do than implant removals. So you may find that cadre is able to easily take on the removal of IUDs, but still needs someone else to assist with the removal of implants, depending on the situation for that cadre. Thanks.
Thank you very much, Ashley, for those responses. So for Hannah, I have, again, 3 questions. The first question starts with, thanks for sharing data on the lady health workers' impact in Pakistan. And the specific question is, do you have knowledge of further data or evidence on community health workers or of task shifting in terms of impact? This could be from meta-analysis, from studies, or from other sources. Then the second question, what is the coverage of lady health workers in India? And does the 75 cents per lady health worker include costs of materials and transport? I guess that refers to Pakistan. Then the third question is on supervision. Supervision of healthcare workers is always a challenge, and is likely to be even more challenging for outreach workers. What are the special interventions or the extra effort put in terms of supervision? Over to you, Rehanna.
And meta-analysis are definitely available, and these are with the Ministry of Health. We can access that and share it with you. It's an ongoing program, and as I said, it's part of the health system. It has its own MIS as well as There are ongoing evaluations done by the Oxford Management Policy. So all that is available. Regarding the coverage, I didn't quite catch the question, but talking about the cost of transport, since the lady health worker is from within the community and lives right there, there is no cost of transport as such, but she is given an allowance because the lady health worker is actually linked to the basic health unit within that area. And she is given an allowance as well as her supplies come. She has to go and collect her supplies from the basic health unit, and she also gets an allowance on that particular trip. So there is a place for that. As I said, the overall, her salary is only $343 USD annually, but the overall cost of one LHV is $745. So all that is built into that cost. Regarding supervision, the number is pretty good. That is, for every 23 LHWs, there's one supervisor, and there are monthly visits to the facility where not only there are monthly updates and reporting work is done, but also in the field, there are provincial and district coordinators, health coordinators, who visit the lady health workers. It is a very well-designed system, and it is, obviously there will be areas, weak areas and stronger areas, but on the whole, we find that it is functioning, and being part of the health system gives them security, job security, and that's what, you know, they know that they are accountable. And obviously the community itself is also brought into play through the health committees that are formed in the community. So they too can give feedback and report on the work that is being done. And of course, there are complaints which are dealt with. So the system is very well designed. Thank you, James.
Yeah, thank you very much, Rihanna. And thank you to all our presenters today. And thank you also to all our participants for being very engaged. And you can visit us on our website and follow us on Twitter. And the webinar is going to be posted at the HRP video library. So we will be circulating this in case you have colleagues who are not able to attend or you'd like to listen to the webinar. It will be available there. We are about actually 2 minutes over, which thanks to everyone for keeping time. And please do have a good afternoon and good morning, good evening, depending on where you are. Bye-bye.